Bismillah ar-Rahman ar-Rahim. Good evening again, our dear friends, the big CEC family and community from all over the world. Tonight, we are launching the waves of the best of ECC 2021. I'm very glad and honored to have with me on board Professor Haitham Suleiman and Professor Karim Mahmoud from the CEC board, as well as Professor Mohammed Abdeshafi and Professor Ahmed Farid. They will be talented speakers tonight. Professor Ahmed Farid is a consultant and lecturer of cardiology at Suez Canal University, and he will give us a short introduction about what was new in the European Society of Cardiology meeting 1 month ago regarding the guidelines and the trials. And then he will discuss thoroughly with us the valvular guidelines that were updated this year. Dr. Mohammed Abdeshafi will follow up by a discussion of 2 of the landmark trials, the Tomahawk trial and the DAPT, master DAPT trial. Both of those trials will be discussed thoroughly in a nice and scientific manner. Following this wave, we will have several waves also in the next 3 Thursdays, discussing all the 4 guidelines and all the major landmark trials. So I will leave the mic now to Dr. Ahmed Farid. He will start his lecture. So please go on, Dr. Ahmed. You can share your screen.
Good evening, dear colleagues and my friends. It's my pleasure to be this night with my respectable colleagues from the CEC channel to represent the first wave of the ESC Congress, the summary of the ESC Congress 2021. We will give a short notice about the ESC Congress 2021. Well, it was very rich in the scientific content, where it was presented some new guidelines and a lot of trials that are of critical importance that we will talk about some of them today. The guidelines, there are 4 new guidelines: the guidelines for diagnosis and treatment of acute and chronic heart failure, the guidelines for the management of the valvular heart disease, the guidelines for the cardiovascular disease prevention in clinical practice, and the guidelines on the cardiac pacing and the cardiac resynchronization, and published this sorry, I have been
yes, you have been disconnected. Yes. You can start after the first slide. No problem.
Okay. So these are the trials, and today we're going to talk about the valvular heart disease, which is a very hot topic, and it's very rich new guidelines with a lot of new concepts and new recommendations. So bear with me, it's a little bit big, but we'll try to make it as simple as possible. The first question we need to ask ourselves: why do we need new guidelines on valvular heart disease? Especially, we had relatively recent guidelines from the European that had been published in 2016 and the American that had been published in 2020. So why we need new guidelines? We have some new points that we have implicated our practice and change our recommendations, like the current practice regarding the intervention and the medical management have been reanalyzed again. The revolution and rapid evolution of the 3D echocardiography, the cardiac CT, the CMR, and the biomarkers play a more and more central role for the diagnosis and management of the valvular heart disease. The new definition of severity of secondary mitral regurgitation based on outcome of the studies on intervention. And I think the change in these guidelines regarding the secondary mitral regurgitation is one of the most important points raised in these guidelines. Also, there is some new evidence on the antithrombotic therapies in patients with surgical or transcatheter bioprothesis, And there, the recommendations for the newer anticoagulation are reinforced in patients with native valvular heart disease, except for significant mitral stenosis. Also, there is some new evidence on the we have also the risk stratification for the timing of intervention as the evaluation and the progression in asymptomatic patients based on the recent longitudinal studies, mostly in the aortic stenosis patients. And we will see that there is some changes in the threshold for intervention in patients with aortic stenosis. And there is current evidence to inform the critical role of the heart team for the choice for the mode of intervention, which should integrate the clinical, anatomical, procedural characteristic beyond the conventional scores and inform patient treatment choice. Also, the surgery have noticed increased experience and procedure safety, leading to expansion of the indication toward earlier intervention in asymptomatic patients. And this is very noticeable in these guidelines. Also, the transcatheter technique sorry. The transcatheter techniques have new information from the randomized studies comparing TAVI versus surgery, and the transcatheter edge-to-edge repair is increasingly used in a secondary mitral regurgitation and have been evaluated against optimal medical therapy, as we will see. And also the studies in the transcatheter valve and valve implantation for the first time to be indulged in the guidelines, we will see in these guidelines. And also there is a preliminary experience in the transcatheter tricuspid valve intervention with some new data. So what these guidelines offer, these guidelines are a little bit systematic and has each topic to be discussed in details. We will have some new recommendations for the aortic regurgitation, for the aortic stenosis, for the mitral regurgitation, either the primary or the secondary, the tricuspid regurgitation, either also the primary and the secondary, the prosthetic valve selection, the antithrombotic management of valve replacement or repair, the prosthetic valve dysfunction, the atrial fibrillation in native valvular heart disease, management of oral anticoagulation perioperatively in these patients, and the concept of hard valve center. So without any further ado, let's dig in through this heavy topic. And we will start by the aortic regurgitation. And what's new here that we don't wait for the left ventricle to be markedly dilated to intervene. So now the cutoff value for intervention is more than 50 is class 1, where it's relatively before it was a bigger ventricles. Also, it's now not depending on the LV in the diastolic dimension anymore. We only depend on the left ventricle in the systolic dimension more than 50, or an indexed left ventricle in systolic dimension more than 25 millimeter per meter square, and this is class 1 indication. Even for smaller ventricles with ejection fraction more than 55 is now class 2B, and this is a completely new indication for the intervention in very small ventricles. Also, the aortic valve repair decreased from the 2B to class 2B and became more strict to experience its center with good results. It was previously in the previous guidelines, the repair was getting a good notion to be a class 1, but the outcomes of the repair is not that successful and not that impressive as in the mitral regurgitation. So it's downgraded to class 2B. Also, they put in these guidelines a solid criteria for diagnosing the severity of aortic regurgitation, and this is the echocardiographic criteria for definition of severe aortic regurgitation. It's not different from before, but it's mentioned here in clear terms and numbers. And what is also very important and very interesting in these guidelines that it provides an algorithm, simplified, updated algorithm for each valve and the management. So it is very important to look at these algorithms. This algorithm for patient with aortic regurgitation is there is significant enlargement of the ascending aorta. If yes, then go to surgery. If no, then if it's severe aortic regurgitation, if yes, with symptoms, and then if it's not
Yes, Dr. Ahmed, I think you need to restart at the section of the aortic regurgitation, the flow chart.
The flow chart? Okay, I will start again. So the flow chart of the aortic regurgitation, it starts by if you have significant enlargement of the ascending aorta. If yes, then proceed with surgery. If you have severe aortic regurgitation, if you don't have severe aortic regurgitation, you go with follow-up. If you have severe aortic regurgitation, is it symptomatic? If yes, go with end systolic dimension is more than 50 millimeter, or an indexed left ventricular end systolic dimension more than 25 millimeter per meter square. If yes, then you go for surgery. Now move on to the aortic stenosis. And for the aortic stenosis, the symptomatic severe aortic stenosis is still class 1, but the aortic valve area and the indexed aortic valve area has been added to the statement of defining severe aortic stenosis in these guidelines. So now it's not just the P gradient more than 4 or a mean gradient more than 40 millimeter mercury. It's also added that the valve area less than 1 centimeter square or 0.6 centimeter square per meter square. Also, there is a new indication. It's class 2A to proceed with intervention in asymptomatic severe aortic stenosis with ejection fraction less than 55% without any other cause. So it's what was in for 50%, it's now for 55%. So we can see that we are now going to intervene earlier in this patient before the left ventricle is going to be knocked out, before the left ventricle is markedly dilated. So these items are going to go with earlier intervention for these valves. Also for patients with asymptomatic severe aortic stenosis with normal exercise test, and that's new compared to the previous guidelines, with low surgical risk and one of the following. Either very severe aortic stenosis or severe aortic calcification. This is a class 2A classification to go for intervention in the aortic valve. And here, the definition of very severe aortic stenosis has differed from the old guidelines. That is now if you have mean gradient more than 60 or Vmax more than 5 meters per second. In the old guidelines, it was Vmax more than 5.5. So as we can see, we are going in an earlier and earlier stage. The definition of severe valve calcification, it's not dependent on echo, it's defined by the cardiac CT, and this is what has been changed compared to the previous guidelines. Also, the markedly elevated DNP levels more than 3 times the upper normal level for the age and sex corrected normal range, confirmed by repeated measurement and without any other explanation in patients with asymptomatic severe aortic stenosis, is a class 2A indication for intervention in these valves. And we have some randomized controlled trials comparing the TAVI versus the surgical aortic valve intervention in the patient with high risk, in the patient with intermediate risk, and the patient with low risk. And all these have led to change in the recommendations in these. Long-term outcome, we can see there's no big difference in the long-term outcomes between both patients. So based on this, the choice between the surgical and transcatheter intervention or the TAVI must be based on careful evaluation, clinical, anatomical, and procedural factors by the heart team, weighing the risk and the benefit of each approach for an individual patient, and this is class 1. But note that the surgical intervention is recommended in younger patients, and the definition of younger patient here is less than 75% with a low risk score, Euro score less than 4%. So here, if you have a patient that is low risk surgical score and he is relatively young, less than 75% of 75 years of age, you can go for the surgery rather than TAVI. But TAVI is not only for patients not suitable for SAVR, but also for older patients more than 75 years or with high Euro score. And this is also class 1 indication. And also there is wider place for choice between the TAVI and the surgical aortic valve replacement based on clinical, anatomical, and the procedural characteristics. So now you have more room to change this using the discussion based on the clinical and based on the heart team discussion decision. Here, this is a new indication for the non-transfemoral TAVI. If you had using the transapical, like if you can use the transapical, this is now class 2B. It's not in class 1 or class 2A, it's class 2B to use the non-transfemoral TAVI. And these are some very interesting criteria to help you to choice, to select the right choice for your patient, either to go with TAVI or go with the surgical aortic valve replacement. It depends on some clinical characteristic and concomitant cardiac condition requiring intervention and in anatomical and procedural factors. And you put this all together and to calculate which, while your patient will get benefit from the TAVI or from the surgery. And this is very solid points. And this, for the first time, you see this very solid like this. And I like this very much. And as I have said, the algorithms here are very simple and very updated. If you have a patient with severe aortic stenosis, if he is symptomatic or not, if he is symptomatic, then you should go for intervention. If the patient is asymptomatic, then you look at the ejection fraction. If it is less than 50%, and if he's physically active, and then you can do exercise tests. And the symptoms, if he had abnormal exercise tests, like if he has symptoms or sustained fall in blood pressure, then you go for heart team evaluation. If no, you look for other indications and go for the heart team evaluation also. And then at the table of the heart team evaluation, you look for if the patient is less than 55 years of 75 years of age, if he has low Euro score 2, less than 4%, or how unsuitable for TAVI and operable, then you go for surgical aortic valve replacement. All other patients, you can go with surgical aortic valve replacement or TAVI according to what's available and the expertise in your center. But if you have an older patient, older than 75 years, with unsuitable or high risk score or suitable for TAVI, then you go for the TAVI. And this is another algorithm for the valve morphology. If you look by the echocardiography and you found the valve morphology that is suspicious of aortic stenosis, then you assess the velocity and the gradient. If you have high gradient with a Vmax more than 4 or mean gradient more than 40, if you have any high flow status. If no, then this is a true severe aortic stenosis. If yes, then you look if this flow status is reversible or not, and then you reassess your patient again. If you have low gradients, like if you have a Vmax less than 4 meters per second or a mean gradient less than 40 millimeter mercury, then you look for the aortic valve area. If your aortic valve area is less than 1 centimeter square, then you recheck your measurements, you recheck the blood pressure and exclude measurements error, and then define the flow status. And you define the flow status by calculating the stroke volume index. If it is less than 35 milli per meter square with an ejection fraction that is impaired, this is low flow, low gradient aortic stenosis. If the ejection fraction is more than 50%, then you go for an integrated approach to consider it is this a paradoxical or this is a measurement error. If you have an ejection fraction less than 50%, then you go for the vitamin stress echocardiography for the flow reserve. If yes, you have a flow reserve, this is a true severe aortic stenosis. If the aortic valve area increased with the test, then this is a pseudo severe aortic stenosis. If you have the ejection fraction is more than 50%, then you look for the cardiac CT to evaluate for the aortic valve calcification, as we had seen in the class 1 indication. Moving on to the mitral regurgitation. And for the severe primary mitral regurgitation, there is a new defining criteria for the LV dilatation for intervention in the primary mitral regurgitation as the left ventricular end systolic diameter more than 40 instead of 45 in older guidelines. So it goes with earlier intervention before significant LV dilatation occur. And if there is LV dysfunction, ejection fraction less than 60, and this is class 1. So if you have a severe primary mitral regurgitation, asymptomatic with an end systolic dimension more than 40, ejection fraction less than 60%, then this class 1 indication to intervene in this valve. But if this patient is asymptomatic with preserved ejection fraction more than 60%, and the left ventricular end systolic dimension less than 40%, and you have UAF that's secondary to mitral regurgitation or pulmonary hypertension with a systolic pulmonary artery pressure more than 50 millimeter mercury, this is a class 2A to intervene in this patient. Also, the mitral valve repair threshold also had been changed to lower numbers of left ventricular end systolic dimension. So now, if you have an asymptomatic severe primary mitral regurgitation with normal ejection fraction with a left ventricular end systolic dimension less than 40 instead of 40 to 44 in the old guidelines with significant left atrial dilatation, even the flail leaflet has been taken out from the new guidelines, you can proceed with mitral valve repair if this is low surgical risk patient and with a durable repair. This is a class 2A. And also, this is the algorithm for the approach of severe chronic primary mitral regurgitation. Is it symptomatic? Then you judge the operative risk and judge by the heart team. If a high risk of fatality, then you go for palliative care. It's an inoperable or at high risk surgery. Then you go for transcatheter edge-to-edge repair. If no, then you go for surgery repair whenever possible or valve replacement. If you have an ejection, if you have an asymptomatic severe primary mitral regurgitation, then you look for the ejection fraction. If it is less than 60% or in systolic dimension more than 40 millimeter, then you go for surgery. If no, you look for if there is an AF not explained by any other etiology rather than the mitral regurgitation or the pulmonary systolic pressure more than 50 millimeter mercury, then you go for the likelihood for durable repair, and you can, if you have a site with a competent, then you go for mitral valve. Regarding the DAPT trial that had been done in the United States patients that had been using the guidelines and cutoff values for secondary mitral regurgitation in the American guidelines, it's used to compare the use of mitral clip versus the medical treatment over 24 months, and it found a big difference and significant difference toward the use of mitral clip rather than the medical treatment in all-cause mortality and in all hospitalization of heart failure. So this raised the issue: what was the difference between the COAPT trial and the MITRA FR trial? And the main possible reason is the cutoff value for diagnosing the severe mitral regurgitation. And based on these data and recommendation, a new indication to intervene in severe secondary mitral regurgitation who remain symptomatic after guideline-directed medical treatments, including the CRT, it's class 1, and another new indication for the transcatheter end-to-end edge-to-edge repair have been in class 2A. And the lower cutoff value for the ejection fraction less than 30% had been omitted from the new guidelines as a contraindication to severe secondary mitral regurgitation surgery if a patient is undergoing CABG. And also, the transcatheter edge-to-edge repair in these patients with mitral valve, if a fulfilling criteria of successful repair and the preoperative assessment, it's also an indication and increase from 2B to 2A in the new guidelines. But if it doesn't fulfill the criteria for successful repair, it's still in class 2B indication for the transcatheter edge-to-edge repair. Moving on to the mitral stenosis, there is no big changes in the mitral stenosis. It just made a simplified algorithm for the rheumatic mitral stenosis approach, and they mentioned the new scores, echocardiographic scores for the accessibility for the feasibility of percutaneous mitral commissurotomy using the Wilkins score, the Cormier score, and the echo score revisited, and these are the new in the mitral stenosis. Moving on to the tricuspid regurgitation, and in concordance with the left side, we don't want the right ventricle also to be markedly dilated and impaired. So here, only the right ventricular dilatation with severe primary tricuspid regurgitation, it's now class 2A, but not the RV dysfunction as before. Also, even with severe secondary symptomatic tricuspid regurgitation without previous left side surgery, we don't wait till the right ventricle is dysfunction, and this is class 2A to intervene in patient with severe secondary tricuspid regurgitation with and without previous left-sided valve surgery if he is still symptomatic. Also, a new indication for patient inoperable with severe symptomatic tricuspid regurgitation by using the a completely new indication by putting the transcatheter intervention in the tricuspid valve, and it's now class 2B. And moving on to the antithrombotic management of valve replacement or repair, and there is a new indication for AF patients more than 3 months after bioprosthetic valve implantation to use the NOACs after 3 months of the bioprosthetic valve implantation, but in the first 3 months, still the vitamin K antagonist is indicated for aortic bioprosthetic heart valves. And the NOACs may be considered over vitamin K within 3 months in mitral valve position with atrial fibrillation, and this is class 2B. And this is an approach, the algorithm for the approach of the antithrombotic therapy for the prosthetic valves. And the antithrombotics in TAVI, it has a very grown in these new guidelines based on a lot of trials. The popular TAVI cohort trial and the popular TAVI cohort comparing the aspirin to the dual antiplatelets, and also the Galileo trial that comparing the rivaroxaban to the aspirin alone, where they found that the death of thromboembolic event is significantly higher with rivaroxaban, with major bleeding significantly higher in rivaroxaban arm compared to aspirin. So a new indication of oral anticoagulation for TAVI with other indication for all oral anticoagulation, but contraindicated if no baseline indication for oral anticoagulation. This is a class 1, and the single antiplatelet has been upgraded from class 2B to class 1 for TAVI patient with no baseline indication for oral anticoagulation. And the routine use of oral anticoagulation is not recommended after TAVI in patient with no baseline indication for oral anticoagulation, and this is now a class 3 indication. And also, the oral anticoagulation should be considered class 2A if reduced left rate motion or significant valve calcification of the TAVI valve with elevated gradients until the resolution of these high gradients. Regarding the perioperative antithrombotic management, and here we run through this in brief. There is a new clear definition of cases where bridging of oral anticoagulation is needed, like the mechanical prosthetic valves, AF with significant mitral stenosis, AF with a Chad's-Vosk score more than 3, acute thrombotic event within the previous 4 weeks, and high acute thrombotic risk. And the new definition for INR aim prior to surgery, you now need to go to discontinue the vitamin K antagonist until you reach an INR less than 1.5 preoperatively to send the patient for surgery. And the new point about the aspirin maintenance peri-procedurally, it's now class 1 to have undergone valve surgery with an indication for post-operative therapeutic bridging. It's recommended to start either with unfractionated heparin or low molecular weight heparin 12 to 24 hours after surgery. Now we move on to the, if you have a patient with a PCI and or acute coronary syndrome that need to be on oral anticoagulation for valvular heart disease, then after uncomplicated PCI or acute coronary syndrome, which is requiring long-term oral anticoagulation, early cessation, less than 1 week of aspirin and continuation of dual therapy with oral anticoagulation and P2Y12 inhibitor, preferably clopidogrel, for up to 6 months and up to 12 months in acute coronary syndrome is now class 1 from class 2 in the old guidelines. Regarding the atrial fibrillation in native valvular heart disease, the left atrial appendage occlusion, either by excision or external clipping, had been upgraded to class 2A. And if the Chad's-Vosk score is more than 2, undergoing valve surgery, so you should close it. It's now class 2A. And also the NOAC have been upgraded to class 1 in preference over vitamin K antagonist in stroke prevention in AF patient with not valid in mitral stenosis. Is unlikely and the criteria for the heart team and additional specialists if required, like the heart valve specialist, electrophysiologists, and geriatrician, and other specialties. And the requirements, like you should have a multimodality imaging, including echocardiography, cardiac CT, CMR, and heart valve clinic for outpatient and follow-up management. So my conclusion for earlier intervention is what we can see clearly in these new guidelines: new indication for transcatheter interventions, and new values for the secondary mitral regurgitation, and new and more solid data regarding the antithrombotics, and more emphasis on the heart team and heart valve centers. And thank you.
Thanks a lot, Dr. Ahmed, for this great lecture. It was actually a very heavy to discuss all the valvular guidelines in half an hour, but actually it was highlighting the important updates and the changes. And if I'd like to emphasize one of those important points, it's the earlier the intervention in the aortic regurgitation and the aortic stenosis, and specifically in the mitral stenosis and the mitral regurgitation. I mean, if you intervene at an end systolic diameter less than 40 millimeters and an ejection fraction is more than 60, so you are necessarily intervening on a patient with a normal left ventricle on the echo regarding the dimensions. And this shows that the pathophysiology of the mitral regurgitation is that mitral regurgitation begets mitral regurgitation, that it begets more and more mitral regurgitation and leads to left ventricular failure and left ventricular dilatation. So essentially, the earlier you intervene, the better. And with the progress of the techniques on the surgical side, and also the progress of the techniques on the interventional side for those patients who are not fit for surgery, so actually the earlier the intervention is also the better. Maybe Dr. Karim Mahmoud, you have a point to discuss, followed by Dr. Haitham.
Thank you, Ahmed. Elegant presentation. Let me ask you about some questions. The first one regarding a patient with a severe aortic regurgitation, not reaching the limits for intervention. However, the patient is presenting with some vague symptoms. You are not sure about that his symptoms is due to aortic regurgitation or something else. So how would you manage these patients?
I will look carefully for his echocardiographic parameters according to the new guidelines. Look for the end of the end systolic dimension if it is more than 40, looking for the ejection fraction if it is less than 55%. And even if he is symptomatic with this finding, I would send him for surgery. And I think there is no rule for the exercise stress test in these patients, in the patient with aortic regurgitation, but I will do a very close, if these findings are not there in this patient, I will do a very close follow-up by echocardiography, even if every 3 to 6 months, to see if there is any recent change about that. I hope this answered your question.
Yes, thank you. And what about if the patient of aortic regurgitation had aortic root dilatation? What are the cutoff values to send this patient for aortic root replacement as well?
Yes, there is no change in the from the previous guidelines, like in 55 without any other chronic illnesses, 50 in patients with Marfan syndrome, and 45 in high-risk patients to develop aortic dissection. So there is no change from the previous guidelines for the intervention in the aortic root and the aortic valve according to aortic root dimensions.
Thank you again, Ahmed. If we discuss aortic stenosis, and now we have the CT as one of the tools for assessment of aortic stenosis. So, so can you tell us how you would you use the CT for assessment of severity of aortic stenosis? We know that the CT can use for assessment of TAVI, but how you can use the CT for assessment of severity of aortic stenosis?
Yes, this is a very good question, and this is a very underused tool we are using for the assessment of helping in assessing the aortic stenosis by CT. We use only the calcium score. and you look for the calcium score of the aortic valve itself, not the coronaries. If you have more than 2000 calcium score in the aortic valve, this is significant calcification. And how this would help? This would help you if you have findings going with a paradoxical low flow aortic stenosis, like if you have a peak velocity less than 4 meters per second, mean gradient less than 40 millimeter mercury, but the stroke volume index less than 35 millimeter per beat, but your ejection fraction is still preserved. And then you're going to calculate the aortic valve area, and you found the aortic valve area is less than 1 centimeter square. So you are dealing now with a paradoxical low flow low gradient. If you plan to send this patient for surgery, you should send this patient for a cardiac CT calcium scoring scan to see the calcium score of the aortic valve itself. If it's more than 2000, so this is a significant calcification of the valve, and you can send the patient for surgery.
Again, thank you so much. I believe it's a very valid point for the using of CT. It actually can be used in the patient with preserved ejection fraction and the patient with low flow, low gradient. Maybe in the patient actually with low flow, low gradient with impaired ejection fraction, if we have a doubtful or impaired systolic reserve after doing the vitamin stress echocardiography, it can be used as well in this situation. So this may be, it's not a new one, but it's also a valid question. How would you choose your patient with mitral regurgitation for mitral repair or mitral valve replacement?
Well, it depends on a lot of items, but according to these guidelines, you have two main factors to judge. The first part, is it a primary or secondary mitral regurgitation? So this will change your decision. The second part is the morphology suitable to be a competent repair after the surgery or not. And then you look for, as we had seen, the outcome and the local expertise level and successful level of doing a competent repair. If you have all these three, you're fulfilling that criteria, and you have a good results for the mitral repair, then you send the patient for mitral repair in preference to the mitral valve replacement. But if you don't have any of these, then do a mitral valve replacement.
So Ahmed, I have an interesting question here from our dear viewers attending with us, Dr. Hanan Mustafa. She's asking you a question about the worsening of the ejection fraction post-severe mitral regurgitation correction. Let me rephrase this question. In Egypt, the mitral repair as a surgical procedure is not yet so famous and not yet valid in all the centers. So what happens is the replacement of the mitral valve surgically by a mechanical bioprothesis. And this, as you know, involves in some centers preservation of the cords, chordal preservation surgery, and in other centers without chordal preservation surgery. And usually you end up a post-mitral valve replacement with an ejection fraction of 40 to 45%. So she's asking about the validity of this procedure.
I think in the most recent years, there is a trend to going with the chordal preservation. So they don't exclude the cords and the papillary muscles during the surgery. This helps to keep the systolic function of the left ventricle. But I think the question, it's asking about something different. It's asking about the worsening of ejection fraction post-severe mitral regurgitation. And this, I think this is what these guidelines are aiming for. You should not wait until your ejection fraction goes down and your ventricle became markedly dilated, and then you send the patient for surgery, because the chance of worsening of the ejection fraction is more if you're going with a bigger ventricle, with a more knocked out ventricle. So this could happen. So you should go early with this. Also, the techniques of the surgery itself, the more prolonged surgery, the more prolonged bypass time, all this lead to knocking out of the left ventricle post-surgical. So it's had a lot of factors, but according to these guidelines, please try to be more early to send your patient for surgery rather than late.
Thanks a lot, Dr. Ahmed, for verifying this point. Karim, do you have any questions on your side?
Maybe regarding severe mitral regurgitation, the patient with the LV dysfunction, the LV function is overestimated in the patient with severe mitral regurgitation. So after doing a mitral valve intervention, mitral valve surgery, the actual ejection fraction is faced after the operation. And the many patients we encountered had such a problem after surgery, expecting that the ejection fraction is improving. However, due to LV dysfunction that present before surgery, this patient will have a decreased ejection fraction after surgery. What do you think, Ahmed?
Yeah, but I agree with you, but we can see that, as you had seen, that with severe mitral regurgitation, the cutoff value of impaired ejection fraction is starting from 60% of ejection fraction, not from 50% like any other valvular or any other guidelines for defining the impaired systolic function. So they are accounting for this in prior to the surgery. So the cutoff value for severe impaired left ventricle with severe mitral regurgitation is 60%.
This is because of the the message because of the loading condition. It depends upon the mitral regurgitation is a preload to the left ventricle, and this preload, according to the physiological Frank-Starling law, already stretches the left ventricular muscle, and this leads to a higher stroke volume so long as you are within the limits. But actually, there are several echo techniques now that are not load dependent at all, that just look at the myocardium, like the strain and the strain rate and the deformation studies. And I think those studies are now uprising in the early detection of the subtle changes in the left ventricular myocardium, especially in this area of the mitral regurgitation. I know that Ahmed is a very experienced imager. Maybe he can give us a very short comment about this point.
Yes, that's thank you, Dr. Mohammed. But I have 2 points here to raise. In the case of severe mitral regurgitation, the ventricle is trying to push all the load to the circulation. He has now 2 ways. The aortic way, which is have a very high pressure, like if you have systemic blood pressure, and a low and more easy way, it's toward the ejection fraction. So it's contract more forcefully to be able to make some cardiac output to the circulation in the difficult way rather than the easy way. So when you close the mitral valve, when you close that the mitral regurgitation, the only way for the ventricle is go through the hard way through the aortic and the systemic circulation. So this put an extra load on the ventricle. That's why the left ventricular ejection fraction post-operatively in these patients looks a little bit lower. But also, there is some new techniques for assessing the left ventricular and the left ventricular systolic function, not the ejection fraction. The ejection fraction is misleading because it's load dependent. You can use the strain imaging, and strain imaging is less load dependent compared to the ejection fraction, and it gives you idea about the actual numbers. And you have some cutoff values. If you have a strain rate, global longitudinal strain, more than -20%, you have a totally normal systolic function. If you have from 16 to 20, this is a borderline, and less than -16, you have an impaired global longitudinal strain and start of asymptomatic LV dysfunction.
Thanks a lot, Dr. Ahmed Farid, for this wonderful lecture. And Dr. Karim Mahmoud, please introduce the next speaker.
I want to ask a very hot question before moving to the next speaker. Ahmed, we faced many times the patients with isolated tricuspid regurgitation. Maybe this patient had previous left-sided heart disease. So how to deal according to the guidelines and according to your experience with those patients?
That's a very good question, and I think we highlighted this during the presentation. If you have a primary severe tricuspid regurgitation with the patient symptomatic, then you should intervene in this patient. If you have a secondary severe tricuspid regurgitation with and without previous left ventricular surgery, and the patient is symptomatic and still in good medical treatment and still symptomatic, you may be opted to send this patient for surgery, either for repair or even for the transcatheter, and it's now a class 2B indication.
but we should have accepted right ventricular function to send this patient for surgery.
Actually, they didn't mention the RV function, but they are still stressing that you should go before the right ventricle is knocked out and it's markedly impaired. So they didn't mention the RV function or the RV dysfunction as an indication to intervention. They only mentioned that the right ventricular dilatation is an indication. So severe tricuspid regurgitation is a primary or secondary with RV dilatation, and symptomatic is an indication for intervention in the tricuspid valve.
Okay, thank you, Ahmed. We have a very fruitful time with you, and now let's move to Professor Dr. Mohammed Abdeshafi, the lecturer of cardiology at Suez Canal University, with two important landmark trials that presented in ACC in the last ACC. Dr. Mohammed, please share your screen.
Okay. First of all, I'm very thankful to be introduced to this prestigious group on this prestigious platform, the CEC, which is purely dedicated to science and moved on by a very dedicated and passionate group of clinicians and researchers such as yourself. So I'm very thankful to Dr. Karim, Dr. Mohammed, and Dr. Haytham, and of course, Dr. Ahmed Farid, introducing me tonight. As previously mentioned, I'm going to present to you today two of the very important studies or trials that has gained a lot of attention amongst many hot trials in ESC to 2021, which are the Master DAPT and the Tomahawk. Maybe the Master DAPT is going to gain more attention today because of the extensive background behind the trial, a long journey leading to such a trial that we are going to discuss in order for us to understand the context of the trial and to fully grasp the clinical implication of such a trial, followed by the Tomahawk trial addressing the way to go with out-of-hospital cardiac arrest, especially as regards to how early and invasive strategy, diagnostic and intervention should be adopted in this patient, taking into consideration that a lot of these events are related to myocardial ischemia. So our agenda today, beside the trials, is going to go across all the three stations, the background of each trial, the trial itself regarding its design and results and conclusion, and the discussion, which hopefully is going to be fruitful with you. It's an open discussion at the end of each trial, or if opted by the operators of this meeting, we can delay the whole of the discussion to the end of the discussion of the two trials. So starting with the Master DAPT trial, the background of the trial, as I said, is extensive. Along the history of coronary intervention, we have been tripping through a lot of Achilles heel. The Achilles heel of treating coronary artery stenosis interventionally moved from new endothelial denudation and dissection following plain old balloon angioplasty, which has been conceived by the introduction of stents, but also the Achilles heel of bare metal stent has been the high incidence of restenosis and stent restenosis, and this has led to the evolution of stent technology to drug-eluting stent in order to address this issue. But with the new solution came a new problem. The delayed endothelialization due to the drugs inhibiting new intimal hyperplasia introduced to us a major problem, another major problem, which in stent thrombosis, which has been mitigated, of course, by effective and currently, which is regarding the standard of care, dual antiplatelet treatment in order to mitigate the risk of thrombosis when we are dealing with drug-eluting stents. The journey of of the dual antiplatelet treatment started, of course, with single-handedly aspirin taking over, which has reduced, as compared to placebo, the incidence of thrombosis and cardiac events by 22%. Introducing clopidogrel to the equation led to another reduction of 20%. Newer anticoagulants, P2Y12 inhibitors such as prasugrel and currently ticagrelor has additional benefits when added to aspirin as compared to clopidogrel. So we have been effectively and gradually increasing how we manage the Achilles heel of the current treatment strategy of coronary intervention using drug-eluting stent. But with introduction of such a strategy and with such potent antiplatelet agents came a balance that we had to deal with. So in the beginning of using such a strategy, we have a common, like a landmark timing after intervention, which is 12 months, which has been moving around a lot according to the context of the intervention with acute coronary syndrome or chronic coronary syndrome and elective intervention, and introducing new classification for the thrombotic risk and the bleeding risk. But let us settle that whenever we settle for a lower duration than 12 months, whatever the context is, we are dealing with a heavier thrombotic risk and a heavier concern about thrombotic events. And when it happens the other way around, it's the other way around. We are dealing with a more duration of DAPT, which will translate to more bleeding risk. Which patients in which scenario, with which stent, with which group of drugs that will have the perfect balance between the mitigating the thrombotic risk without additional bleeding risk, it's the mainstay of most of the trials dedicated to this area, including the trial we are going to discuss today. And it's very important also from this figure to understand, whenever we are reducing the DAPT duration, as with the case with the trial we are discussing today, and we are more concerned with thrombotic risk, and that's why the main investigators of the trials opted to make a hierarchical multiple endpoints, but they have prioritized the thrombotic endpoint, which is the efficacy endpoint first, because we can care less if we have mitigated the bleeding risk by reducing the DAPT duration if the thrombotic risk remains high. So unless we achieve a non-inferior or rather a superior reduction of thrombotic risk with this new strategy, we are not even concerned with the bleeding risk. So that's why they have prioritized the thrombotic or the efficacy endpoint of such strategy, as we can see or going to see with this trial. One of the ways that has been mitigating this risk as well, the risk of bleeding of the DAPT, which it's going to incur going to see, we are reaching a third generation drug-eluting stent, a lot of which, including the stent that's under discussion today, although it's not like a stent trial, but also it's because almost more than 99% of the trial used a single type of stent. We can say that this stent belonged to this era. The rate of individualization of the new drug-eluting stent is very rapid. At 1 to 3 months, there is a lot of benchmark testing, OCT testing, that has led us to believe that a lot of patients, or the majority of patients, have full individualization of the stent at this area, making it very, very safe approach to cut the duration of DAPT for such like patients. And with the increasing generation of the stent, we are, as I said, of course, increasing the rate by which we decrease restenosis, but however, there is still a residual risk of early and late thrombosis in these patients. We can see here that it is very, very obvious that longer DAPT duration performed very well the lower half of the panel with the first generation drug-eluting stent. The data were consistent that the longer the DAPT duration, the better in these patients. But with the evolving of the stent technology with second and even more so with the third generation stent, the data start to scatter around the midline, which is not consistent, letting us believe that maybe shorter duration might be optimal for such group of patients. This is also one of the backgrounds that led us to believe that with evolving stent technology, this is one of the solutions that might cut down or reduce the duration of that. Other approach other than the stent technology, when you opt to decrease the DAPT duration, that means you are going to opt for a single antiplatelet strategy very early on, because you're going to use DAPT only for a limited period of time, is that the single antiplatelet agent that you're going to depend on from this point on is going to be a superior one, is going to be a better one. Early on, of course, the CAPRI study was not dedicated trial for early stoppage of DAPT. It's a trial that has tested the hypothesis of whether if you can continue on clopidogrel rather than aspirin after 12 months of dual antiplatelet treatment duration. As you can see that there's significantly better relative risk reduction as regard the composites, which will moving on to dedicated trials addressing the very question we are addressing today, by the Stop DAPT trial. They have tested the hypothesis as well that we might stop dual antiplatelet treatment at 1 month. So they randomized the patient undergoing coronary intervention. All of them has received dual antiplatelet treatment using, of course, a single agent, which is clopidogrel with aspirin. The patient were randomized later on for the rest of the year using clopidogrel alone, as opposed to those using clopidogrel and aspirin and completing the year on dual antiplatelet treatment. And also the net clinical benefit that included both efficacy and safety endpoints to the left side of the panel were significantly better with those using clopidogrel alone as a single antiplatelet treatment early on after only 1 month of DAPT, as opposed to those continuing DAPT to the rest of the year. Also, the major secondary ischemic endpoint, excluding the safety endpoint, did not differ. So there was no additional bleeding risk, and there was non-inferior ischemic risk as opposed to a prolonged DAPT duration in this group. So later on, similar studies such as ours continued in order to enforce the concept of a dual antiplatelet treatment as little as possible. The SMART choice trial, the drawbacks of such a trial that they used multiple stents. They were not dedicated toward a certain stent, and they used almost every available P2Y12 inhibitor according to the discretion of the treating physician. So although it was a positive study, but there's a lot of noise as to whether this might be related to a certain stent or a certain drug. The Global Leaders trial was a very good trial, but it did not achieve the endpoint, but because the endpoint at the time was a superiority endpoint, they tried to prove not only that a single antiplatelet treatment strategy early on as compared to dual antiplatelet strategy, and it was a ticagrelor-based study, they wanted to prove that it was superior in decreasing ischemic event, which was not the case. It was equal, and I believe if it was a non-inferiority trial, I believe it was going to be positive, but because it was a superiority trial, it was negative. And lastly, they have done a one that is more suitable, which is the Twilight, and later on the Twilight complex trial, which used the same concept as 1 month of DAPT, including ticagrelor, and continuing ticagrelor as compared to aspirin, and it was a positive trial. The last issue before going to our trials, all of the later trials that I have just mentioned did not mention the specific group that we are mentioning today. Of course, we are trying to mitigate the bleeding risk by shortening the DAPT as much as possible, but it was the spectrum of the whole population of those undergoing coronary intervention. It was not dedicated for those with high bleeding risk. Dedicated trials with high bleeding risk are rather scarce and are limited, and a lot of them, they are comparing current drug-eluting stent to previous drug bare metal stent, or even to historical cohort of bare metal stent. Those are on the left side, and the newer ones, which are comparing short versus standard DAPT duration, such as the study we are discussing today, are still going on, so we don't have the results yet. And this is what we opted for at the end of the day, that with high the current practice and low scale those with stable coronary artery disease, there are high bleeding risk. It is class C, so it's just clinical consensus. And the class 2B, the power of indication is not that. So the hypothesis was that a shorter DAPT duration, only 1 month of dual antiplatelet treatment followed by a single antiplatelet treatment, is not going to be inferior as regard the efficacy endpoint of a major adverse cardiac and cerebral events as compared to prolonged DAPT, continuing for at least further 5 months after the first month of DAPT. And superiority that is going to superior as regards mitigating the bleeding risk or bleeding event, which was defined as the major or clinically relevant non-major bleeding in this population. So it was mandatory that all patients took DAPT for 1 month. All the patients had Ultimaster stent or Ultimaster Tensase stent. It was according to the discretion of the physician to use whatever PTY12 inhibitor beside the aspirin. It was not mandated that a certain agent be used beside aspirin, whether we are talking about the first month of dual antiplatelet treatment or about the single antiplatelet treatment that's going to be continued, or the DAPT that's going to be continued for further 5 months, unless the patient had a compelling indication to use an oral anticoagulant. In this way, if he's going to continue on a single antiplatelet treatment, it has been that he should choose either aspirin or clopidogrel, or the second arm with prolonged DAPT, which are going to be used beside the oral anticoagulant. They also had to be a combination of aspirin and clopidogrel and no other P2Y12 inhibitor. It is worth mentioning that half of the patient at baseline, the indication of treating them with stents with acute coronary syndrome. So we are not just addressing high bleeding risk population above 18 years, we are also addressing a population with high thrombotic risk, which is very important point of the study to be generalizable to the vast majority of patients we are treating each day with a stent. So the eligibility after index procedure, that the patient had a high bleeding risk. The definition of high bleeding risk in this patient, it was either one of two, which the first is the patient has a precise DAPT score of 25 or more, or one or two or one or more of a lot of criteria that indicated high bleeding risk, either a systemic disease in which there is high bleeding risk like thrombocytopenia or high NR. The patient had a thrombotic event in his stents along the past 6 months, a stroke along the past 6 months, age 75 years or older, and if the patient had been receiving oral anticoagulants. A lot of issues. 17%, only 17% of patients were allocated as have high bleeding risk due to the age alone, which is 75 years of age or more. And it's worth mentioning as well that 11% of the population, the reason for labeling them as high bleeding risk was that they received oral anticoagulation. It concluded 4,500 plus patients, and the results was as follows. Why do I mention its hierarchical endpoint? Because of course they recorded all the endpoints after the trial ended, but did not move from endpoint to the other unless the first endpoint or the previous endpoint was found significantly in favor of the hypothesis of the trial. That means they addressed first what was called the net adverse clinical event, which was composite of all-cause death, MI, stroke, and major or clinically relevant non-major bleeding. So it was a mix of between the efficacy and the safety endpoint. And because it was found non-inferior in favor or non-inferior as regard the abbreviated DAPT as opposed to prolonged DAPT, they then moved to the other analysis, which is the major adverse cardiac and cerebral events, or what we call MACE or MACCE, which is composite of all-cause deaths and MI and stroke, which is the purely efficacy endpoint. Again, reducing the DAPT duration to 1 month did not increase the thrombotic risk significantly, and it was non-inferior to a prolonged DAPT duration. And finally, the safety endpoint alone, which is the third endpoint, which major or clinically relevant non-major bleeding. And as this regard, there was superior difference in superiority in favor of the abbreviated DAPT duration, was superior to standard DAPT duration, of course, and it goes without saying that this was expected. The conclusion that 1 month of dual antiplatelet treatment following stent implantation in high bleeding risk patient preserves ischemic benefit and reduced bleeding risk. The impact on clinical practice, as mentioned by the trialists, the duration of DAPT in patients at high risk of bleeding was unclear before. In guidelines, they recommend shortening that duration in these patients, but now we are offering even more shortening with accumulative data in high bleeding risk population, a rarely visited population that has been excluded in most major trials. Now we have solid data, or initial solid data, that 1 month of DAPT in this population might reduce the bleeding risk and not compromising the ischemic risk. The SWOT analysis, SWOT analysis of trials, it means the strength, weakness, opportunities, the threats. It is worth mentioning that the weakness, that this was an open label study, there was no masking whatsoever, only one stent platform. This is a double-edged, of course, thing, because using a single stent that reduces the noise about the trial and about the concept of the trial, but of course it may limit the external validation to other platforms or other stents, which is very important to mention. And thank you very much as regarding the first trial. And if the moderators opt for me to continue and keep the discussion for later, I'll continue, inshallah.
Let's take a couple of questions here, if you don't mind, Dr. Abdeshafi. We have a question from the audience. What are the indications of an extended DAPT beyond 12 months? After 1 year, I mean, do you have indicated patients where you choose to put DAPT for more than 12 months? And if so, which drug for which dose?
The options are multiple. We have trials in favor of clopidogrel. We have trials in favor of the ticagrelor as well, with the reduced dose of 60 milligram twice daily. And we have currently other trials regarding the rivaroxaban as well, in a dose of 2.5 milligram twice daily. And this has extended the definition of rather using dual antiplatelet treatment of dual antithrombotic treatment, because of course rivaroxaban is not an antiplatelet drug. We have a lot of tools, and as this trial has defined the high bleeding risk by some certain criteria plus scores, we have some certain criteria plus the scores. So at the time of implanting the stent, we have the DAPT, precise DAPT score. The precise DAPT score is trying to tell us how much risky for us to extend the dual antiplatelet treatment for prolonged duration. Higher scores favors bleeding, so in favor of shorter DAPT duration. Lower scores favors using dual antiplatelet treatment for prolonged duration. The DAPT score as well is used, but it's used and calculated 1 year after implanting the stent. Also, this can be used. Other non-scored items, it's related to the thrombotic risk primarily, and it is related to certain background conditions, such as the patient having diabetes, which one of the criteria that alone on its own has justified using ticagrelor in a prolonged form in the Pegasus trial. So diabetes itself, having multivessel disease, inserting more than 3 stents in the patient, complex procedure, left main procedure, all those in the absence of a high bleeding risk would justify for you to use a prolonged DAPT duration, either clopidogrel with the standard dose with aspirin, either aspirin with ticagrelor 60 milligram twice daily, or aspirin with the rivaroxaban 2.5 milligram twice daily.
Thank you, Dr. Mohammed. Elegant presentation. I believe in the summary of in the design of this study, some patients received oral anticoagulation and other didn't receive. So is there a difference between those who received anticoagulation or not? And the second point I want to comment upon, this trial should be limited to a patient and with the which is biodegradable.
Yes, yes. That is one of the limitations of the study, of course, the external validation to other stent platforms. The trialist mentioned they used it because it already had data, that the Ultimaster had data before, and they have the CE mark of being allowed to be used for only 1 month. Besides their data from OCT trials, the 1, 2, 3 discovery trial, which, as I mentioned before, has proved that the majority of patients after 1 month has almost complete endothelialization of the stent. So this justified. But we have also, especially with other platforms, initial trials and initial data, and that it might be safe, but it has to be addressed alone in a similar study addressing these specific stents. Without mentioning the other types of stents, as I said, 99%, because almost in this population, 4,500 patients, the rate of implantation of stents was around 1.7 stents per patient. That means above 6,000 stents has been implanted. Around 20 of those were not Ultimaster. The true thrombotic events that happened in this trial, the documented stent thrombosis, were 18 events. 2 of them were in these stents that were not Ultimaster stents. So 2 out of 20 stents. The other flip of the coin is 16 events out of 6,000, around 6,500 stents. So this might raise the concern that other platforms might not be as safe. So the external validation, as I mentioned, is a limitation of this trial.
Dr. Abdeshafi, do you have a specific recommendation for antiplatelets duration in patients with ectatic coronary arteries? Or do you give them dual antiplatelets for life? Or do you add a small dose of NOAC? I mean, what's your consensus or what's your vision about those cases with coronary ectasia?
Of course, you are asking me this because you know that there are no specific guidelines.
Yes, there is no specific guidelines. So first of all, this is the right answer. We do not have a specific guidelines about this, but we always like to ask different schools how to manage such a case.
I think it is very much impacted by us as interventionalists viewing ourselves the coronary of the patient. About the event, if this index event is the first for the patient or maybe a repeated one. So actually, in most of the patients, I might opt with a strategy of antiplatelet and dual antiplatelet treatment, considering the patient of high thrombotic risk, and would continue for 12 months of DAPT unless the patient has high bleeding risk, and would continue as well the dual antithrombotic or dual antiplatelet treatment for life with the allocated dose. Using an anticoagulant per se from the start, sometimes you opt for this in repeated events on such a regimen, or very ectatic vessels with very high thrombotic load with visualized thrombi from the very start. We might opt for this, but I think this is going to be an individual basis. But at least for me, I would opt for anticoagulation when there is a recurrent event on that.
Yes, just like any other patient, I mean.
Yeah.
Dr. Karim, do you have any questions or we will move to the next trial?
I think we can move to the Tomahawk trial.
Yeah, it won't take a lot of time, maybe only 5 minutes. So the Tomahawk trial, the word Tomahawk is, it means the axe used by the Native Americans in North America, the Indian Americans. So this is the meaning of Tomahawk trial. That's why this is the slogan of the trial. The background actually is limited, and what opened the question is the COACT trial, which was a negative trial to begin with. But at the time that the COACT trial its results has been published, the Tomahawk trial was already recruiting patients. And what we have about the data from out-of-hospital cardiac arrest and how to deal with them once they are successfully resuscitated in the restoration of circulation, we don't know what to do with them as regarding the strategy of immediate versus delayed coronary angiography. What made us take this path is we know from very also limited trials that around a third or even more of patients with out-of-hospital cardiac arrest have an acute ischemic myocardial event as a cause of their arrest. So being attentive to this very high possibility, common is common, being attentive to this in proceeding directly with such a pathway of treating such patient or managing such patient might sound reasonable, but what has been established that this is tailored only to STEMI patients, meaning that after restoration of circulation and successful resuscitation, there is STEMI in the baseline ECG. There is consensus to do immediate coronary angiography. But in the case of lack of STEMI on the surface ECG, this is the question. And the question that have been addressed by the COACT trial, as we can see here, the 30-day endpoint of mortality was not different among immediate and delayed coronary angiography. And the Tomahawk trial was awaited to either confirm this negativity or to show us a different way to go. And the guidelines, according to the COACT trial, as we mentioned in the highlighted part, therefore it appears reasonable to delay performance of invasive coronary angiography among non-ST segment elevation acute coronary syndrome patients. However, several ongoing trials will further define this, one of which is the trial we're addressing today. So the study flow, it included patients, 554 patients above 30 years of age, successfully resuscitated after out-of-hospital cardiac arrest with a possible cardiac cause of arrest and no ST segment elevation and post-resuscitation ECG, and both shockable and non-shockable rhythm were included. We might, of course, argue about the negativity of such a point of inclusion criteria, but this is the case. They were randomized one-to-one in the hospital to immediate coronary angiography, and the other on initial ICU assessment, and delayed or selective, that means tailored angiography if the patient later on has shown true signs of ischemia, high risk features in his myocardial ischemic event, as was the case of non-ST segment elevation acute coronary syndrome. The primary endpoint was all-cause mortality at 30 days, exactly like the COACT trial. And unfortunately, it was not just negative; it was in favor of delayed strategy. There were greater mortalities among patients with early invasive strategy in this group. In the composite secondary endpoint, which was all-cause death or severe neurological deficit at 30 days, as well, was significantly higher in the immediate versus the delayed angiography and intervention group. And this was the conclusion of the trials, that early coronary angiography in out-of-hospital cardiac arrest patients without ST segment elevation is not superior to a delayed selective approach. And this has led us that we are in a status quo right now. According to the latest guidelines that I have mentioned, the STEMI guidelines, this is 2020 guidelines, it's rather recent. I think nothing is going to be new. We're not going to move forward anytime soon unless something new happens. So we are sticking to the plan that only ST segment elevation on post-resuscitation ECG is the indication of immediate coronary angiography and PCI for such population. And remember, not all Tomahawks are disappointing.
Thanks a lot, Dr. Mohammed. This is a very nice overview for this trial. I think this trial, because sometimes you are faced when you are on call somewhere and you get a patient which was arrested for any cause, and then the patient was successfully resuscitated, and then sometimes he doesn't have the patient, if he has an ST elevation, the ECG, okay, this goes with common sense, he's going to perform a primary PCI procedure. But if the patient does not have an ST elevation in the ECG, sometimes you are asked the question, are we going to perform a coronary angiography or no? So this trial answers the question. There is no emergency at all to perform this procedure unless you have an ST elevation myocardial infarction. This goes with logic, because sometimes the out-of-hospital cardiac arrest is not due to myocardial ischemia. Myocardial ischemia is one of the causes of, or STEMI is one of the causes of cardiac arrest, but it's not the only single cause of cardiac arrest. And the procedure of performing a coronary angiography in those patients and moving them to the cath lab and inside and outside of the cath lab, and whether the hemodynamics are stable or not,
Yes.
usually may interfere with the outcomes of this patient, especially if the cause is another cause rather than a STEMI. I don't have any questions in the chat box. Maybe Dr. Karim, if he has any questions, and then Dr. Haitham will give us a wrap up of tonight's session. So Dr. Karim.
Thank you, Muhammad. I have a comment and a question, Dr. Muhammad. My comment is the number of primary outcome, speaking about mortality in this trial. With a patient with out of hospital cardiac arrest, and this trial, I believe it was done in one of the Western country. Still, half of those patients died. So still, it is a lethal condition, even with a good access to the medical care facility. And the question is regarding what do you think the difference between this trial and the previously mentioned COACT trial?
Actually, in an essence, there is almost no difference. They carried the same endpoint, the same recruitment strategy. Even the arms were almost the same. What happens is that we might have explored differences in very details if a different outcome have emerged. But what happened is that this trial started recruiting and was established to go on before the COACT trial was published. So they had to go on with it. Maybe something different has emerged, but in an essence, there is almost no difference in the general concept or the endpoints or even the duration of recording these endpoints or the recruitment arms. Almost no major differences. Sometimes a repetition like this, when a negative trial comes out, you hope for the best, that you're going to prove something better next time, but it did not go as planned.
Thank you, Muhammad. Yes, it's a confirmation for previous trial. Yeah. And the result, I think it's clear now. We should not move this patient with out of hospital cardiac arrest and non-ST segment elevation acute coronary syndrome to the cath lab unless there is an urgent need. And most of these patients should treated first in the ICU before going to cath lab.
Yes.
Haitham, would you like to wrap up this very fruitful session?
Thank you so much for our elegant speakers, Dr. Ahmed and Dr. Muhammad. You've given us a dazzled journey, whether in the guidelines as an outline or in the valvular heart disease guidelines or in the trials. I think the theme of tonight is to act fast, but to act safe. So the theme of the valvular heart disease is to give a better diagnosis and the reduction of the all the cutoff points to consider this valvular disease for intervention or for more active intervention is obvious in these guidelines. They included more tools to better diagnose and to better elicit whether this is a true valvular heart disease lesion or the problem is in the valve or not. On the other hand, they are tending to do the less invasive or the less risk procedures. It's now emerging as a class 1, whether with the TAVI or whether with the mitral clip. So they are tending to go fast and to go more safe. On the other hand, in the DAPT trial, we are all increasing the safety between the balance of ischemia and bleeding risk. And in out of hospital arrest, it's not mandate or mandatory to intervene or to go to the cath lab, even if this patient have an STEMI, because as we saw in 2 successive trials, this did not improve the outcome. So I think the theme of tonight is to act fast, but to act safe. And I thank you all for joining us today in this elegant trial, and waiting for you in the next weeks to complete the wrap-up of the European Society of Cardiology, weather guidelines, or the late breaking trials. Thank you so much.